Dear Professor Nakatis, Professor Kushanko, Professor Svetlikov, it's a great honor for me to be here in St. Petersburg today with 8 colleagues from our vascular clinic and 3 colleagues from our neurology clinic in Helsinki. It has been very interesting and big honor for me to work together with Alexei to put up this conference, and I'm so surprised to see that you are so many of you all here. I think it will be a wonderful conference today. I was asked to give a short overview over what we are doing in Helsinki at the moment in our Department of Vascular Surgery. You know, Helsinki is situated in the southern part of Finland along the coast, and we have our hospital district will cover 1.2 million people, so maybe not so much if you compare to St. Petersburg, but it's the only university hospital in this area, and also we treat all the vascular surgery for this area. Outside this hospital district, of course, there are smaller hospitals, central hospitals that will send tricky cases to us, and also some cases will come from all over Finland and also from abroad sometimes. We work today in 2 different hospitals, one situated in the very center of Helsinki, the MED122 hospital, and then one situated a little bit more far away, 20 kilometers outside Helsinki city center called Jorvi in the city of Espoo. But it's one department that work together, and we rotate a little bit also to cover all the working places that are in those hospitals. And here you can see a little bit about our manpower and beds. We have 21 beds in MED122, 22 in Jorvi, and we have in all about 5 operative tables a day for elective cases, 1 for emergency running all the time, and then also 1 day surgery table where we usually do mostly varicose vein surgery. And also in the radiology department there are angio teams doing endovascular surgery to the patients. We are 14 consultants and 6 to 8 trainees, and we have also divided a little bit what we do in these hospitals. More emergency will take place in MED122, aortic surgery, carotid surgery, and this is important because we want to have a good collaboration with the neurology that also have their emergencies in MED122. So that's why, considering the topic today, this is important. On the other hospital, smaller hospital, we do critical limb ischemia, access and venous surgery, and also our hybrid suite is in the MED122 department. And here is our staff. Marit Venermo is our professor and deputy chief, and she's doing a lot of endografting to aortics, and Ilkka Kantonen is our deputy chief also. He's responsible for aortic surgery, and also associate professor Petteri Kauhanen is taking care of Jorvi Hospital, and Pekka Aho is doing a lot of aortic and aortic stent grafts. Pirkka here, who is also with us today, is responsible for our carotid surgery, and he's the important man today coming from our hospital to this conference. And here the rest of our staff surgeons and trainees working in our hospital. A little bit numbers, it might be a little bit boring, but I just want to see, to give you a picture that we have quite a large outpatient clinic, about 7,500 patient contacts a year, and if you add up all kind of visits, it will almost end up to 20,000. What we think is important is to have the vascular laboratory taking care of pressure measurements, TCPO2s and things like that. And we also have vascular nurses that do surveillance to bypass grafting, and they do it by ultrasound, and they do quite a large amount of visit they also. You can see our procedure, how it has developed over the years. We have a growing population of old people in Finland, and that's also reflected in this slide. But now you can see that after a huge development on endovascular surgery, it seemed maybe a little bit now to be more steady, the development. And open surgery has stayed on the same level for the last 3-4 years. It hasn't decreased very much despite this huge increase in endovascular surgery. We do a lot of cases as emergencies, about 30%, and almost half our patients will come as unplanned cases. About 60% of all revascularizations are nowadays endovascular, and we are also very fond of our our hybrid procedures that take up about 10 to 15% of our procedures nowadays. And outside our hospital district, we have about 50 to 100 patients a year. And the venous procedures are done mostly endovenously nowadays, about 1,400 cases a year. Here a little bit what kind of procedures is mostly performed in our clinic. Carotid endarterectomy is about 230, and this is also interesting. I see we tend to do about 70% of aortic aneurysms with endografts, but we had our hybrid suite under renovation last year, so that's why it's almost 50-50. And then we do quite a lot of distal bypass surgery still today, even though the big rise in endovascular procedures. What we are especially interested in nowadays is also what we call oncovascular surgery, about 20 to 40, thank you, cases where we reconstruct vessels that tumor had grown into. So when we take away the tumor, we also resect big vessels like vena cava, aorta, mesenteric arteries, iliac arteries, and veins, and so on. That seems to be a growing kind of surgery today. I don't know for how long, but at least that's the picture today. And also, if you look at the endovascular procedure, you can see immediately that the biggest part is distal for leg ischemia. That's a major part of all procedures, and that has grown really a lot. We got our first hybrid suite in 2001, and that was among the first in Europe, and we thought it was very fancy at that time, and it was, but over 12, 13 years it got a little bit old and maybe not so practical, and now we are very happy that we last year could build a new hybrid suite with new technology. You can see it's nice to have these big screens, and also this robotic C-arm is good when you want to convert from open surgery to endovascular. It will be done very quickly. Here our Professor Marit Venermo is operating, and you can see that Seago is waiting in the corner to come into the picture, and it's a huge machine, but so you need to be careful not to get under it, but it works very well when you can very quickly change this environment into an endovascular suite. It's also possible to do Dyna-CT. It will rotate one way around, and you can get a CT-like imaging for different situations. So we have been developing this hybrid surgery now, and before the renovation we did about 300 procedures, mostly stenting, aortic stent graft, PTA, and angiography to acute ischemia, and then a lot of different kind of things where you needed to have an operating environment. And this is maybe the best example, like we heard in the introduction. We are going down in treatment times in the wards from aortic open surgery to 7 to 8, 10 days in open surgery with huge aneurysms. Now you can do it almost percutaneously, and the patient will stay 1 to 2 days in hospital. So this has been a huge development all over the world. And I'm very honored to be able to hear Professor Volodov's talk, how it all started. And also other kind of hybrids we do when we reconstruct the iliac vessels down to the groin with endarterectomy to the groin, and then endovascular recanalizations of these large vessels with good results, we think. And these have been increasingly done over the last years, inflow and outflow PTA in combination with bypass and endarterectomy. So for the future, we think endovascular surgery will have a bright future, I'm sure, and we try to build more endovascular resources for us when we get new hospitals in 2020, and now we will move into our old ward in next years and have 30 beds in Meilahti, and I think we will need them very much. So thank you so much for giving me the opportunity to present our clinic for you today, and I'm sure this is going to be a very fruitful and interesting meeting to come. Thank you very much.